So it is my great pleasure to invite our next speakers on infectious disease. I have a copy of the strategy. Do people have this? Copies? And to introduce Sharon Peacock as our Director of the National Infection Service.
Hello, good morning.
And an even a warmer welcome to Chris Whitty, Chief Scientist for the Department of Health and Social Care, and our next Chief Medical Officer. Thank you.
Thank you.
Thanks.
Thank you. Well, thank you very much for that kind introduction, and a very warm good morning to everybody here. Now, you've heard something about infectious diseases from Duncan this morning, and one of the things that we know is that despite a perhaps arrogant thought in the 70s or so that we might actually eradicate infectious diseases in the end, that's turning out not to be the case. And as we've heard, infectious diseases is an ongoing threat to our public health, both in this country and beyond. So we, in this infectious diseases strategy, are doing exactly what Duncan has said. We are speaking up and stepping up to do something about this. Now, Duncan said we need to move from not good enough to good enough, and that is exactly what we're doing with this strategy. We're doing that by the application of the best evidence for how we get the greatest benefit for our population by what we do and the money that we have to spend. So what we're going to do this morning is to have some slides from Chris Whitty, who I'll introduce a little more in a moment. But he's going to set the scene for the background threats and also some of the tools and great innovations we have to tackle them. I'm then going to walk you through how we got to decide our strategic priorities and what they are. So turning to Chris then. So as you know, Chris is the Chief Scientific Advisor to the Department of Health and Social Care. But as you've already also heard, from October 2019, he's going to be our new Chief Medical Officer taking over from Dame Sally, and the UK Government Chief Medical Advisor. He's also a passionate epidemiologist and physician, a practicing physician, I believe, which is quite extraordinary. I don't quite know how you get the time, Chris. But I'd like to welcome you to the podium now to give your slides. Thank you very much.
Great. Thank you, Sharon. So it's a great pleasure to be here. And in fact, one of my other jobs is I'm a PHE epidemiologist, although I don't tend to write that on the long version of my slides. So I'm really just a warm-up act for Sharon, who's going to walk through the strategy. But we thought it would be sensible to make a few introductory comments, most of which are obvious. I'm going to make four, in a sense, obvious sets of points, and then end up with one challenge to all of us. The first thing we should always think about is epidemics. And the reason we should think about them is politically, I'm talking here small p politically, these are phenomenally important even when they are actually epidemiologically relatively unimportant in historical terms. I put up here the front pages from a variety of epidemics, ranging from massive global pandemics like the HIV pandemic, locally very important epidemics such as Ebola in West Africa and the Zika epidemic, ones that fizzled out very quickly but could have been very problematic like SARS, and of course ones which are of local importance. The point about all of these are massively important to the public. They sell newspapers, and they're therefore of importance politically. So even quite a small epidemic, managed well, massively increases the confidence of politicians and the public in PHE, and it has never happened in my time, but if it were ever managed badly, collectively our own global stock would go down. It is also important to point out that actually epidemics can also have importance, for example, socially and economically, way out of proportion to their epidemiological importance. So take SARS, for example, killed less than 1,000 people globally, tragic for those families, but relatively small in epidemiological terms compared to smoking, for example, but it wiped $40 billion off the world economy, very heavily concentrated in certain countries. So epidemics are important even when they appear relatively modest. But sometimes they're not modest. And of course, the classic example is influenza. I think all of you know this, but I'm using US data, which are possibly slightly less well known in the UK. And if you take the bottom graph, this is one I tend to show to my colleagues in the national security sphere when they are saying, why is it we're worried about flu as the worst threat to national security? Why aren't we worrying about terrorism? Terrorism is very important. I don't want to downplay it. But if you look at the US numbers, more people died in the 1918-19 flu pandemic than all the wars that America fought in the last century combined. An astonishing statistic. And the speed of onset of this was absolutely staggering. You look at the US at a time when transport was much less good than it is at the moment. The dark colours are where it entered the US around September the 14th, and the light colours are where it got to by October the 5th. Very short period of time, and look at the spike of mortality in October. So that is the impact that this pandemic, which had a mortality rate globally of somewhere probably between 50 and 100 million, can have. So epidemics were always politically important and can be extraordinarily medically important. The second group of things I wanted to talk about was childhood infections, and particularly childhood vaccine-preventable infections, because vaccines are going through a period of a lot of discussion in the media and more generally. PHE has a phenomenal track record in its impact with vaccines, and I'm just going to illustrate this with 4. These two are what, when I was training in medicine, were the leading causes of meningitis in children. On the left, Haemophilus influenzae, type B. You can see where the vaccine was introduced. I don't even need to put an arrow on that one. And on the right, what's happened to meningococcus over the last 2 decades. That is a stunning public health achievement. And in my view, almost certainly will be consolidated. Moving to non-meningitis infections, although for the left-hand one, it's true for both, pneumococcal vaccine is having a really remarkable effect on pneumonia in children and in adults, but the proportion in children is more striking. And think about the impact of the introduction of rotavirus. Again, if someone's a vaccine skeptic, just show them that rotavirus slide. It is extraordinary when you think about this as one of the leading causes of diarrhea in kids. And then it is also having an effect in terms of, and the next group I wanted to use an illustration, the vaccine and infection preventable cancers in adults. And I'm again going to just illustrate this with 2. The first of these is cervical cancer. And that has seen already a 40% reduction due to improvements in screening. Is going to improve even on the screening, in my view, with the introduction this year of HPV as the main screening modality. And over the next 2 decades, we're going to see cervical cancer go down to very, very small numbers as a result of the successful vaccine campaign that's going on at the moment. There is, of course, a but in this. Extraordinarily effective vaccine, now very widely used in girls, being introduced very shortly in boys, but the vaccine coverage is only, and this is an important only, but only 84%, was slightly higher when it was first introduced, and we do need to make sure that is maintained. Because it's very clear there is a lot of herd immunity. We need to be absolutely sure that that is maintained over time. And here's one where I think we probably could do even better than we have at the moment, hepatitis B. Again, hepatitis B vaccine, globally and in the UK, should lead to a significant reduction in hepatocellular carcinoma and cirrhosis. A less important cause in people who are UK-born, but significant importance globally and important in certain populations. So these are vaccine-preventable cancers. But not every intervention is about vaccines. And there are a very large number of diseases where the public health intervention is actually around drugs. Clearly antibiotics, I don't need to go through the extraordinary change that antibiotics brought through, TB, which Duncan just mentioned, but also HIV, where we now have conclusive evidence that if people can control their viral load to undetectable levels, they have effectively zero probability of transmitting HIV. This is, again, a remarkable step forward. And the most recent group of drugs which has come on the market are for hepatitis C, where we used to have to genotype, and there are a variety of problems with this. We're now getting to a stage where treating almost everybody with hepatitis C is a realistic possibility. So these are reasons why things have changed substantially for the better. But not everything gets better, and I'm just going to illustrate two, which I think are headwinds we need to take account of. Sally Davis would kill me if I didn't mention antimicrobial resistance. Sally, this is slides for you. Two things to say about this, the first of which is antimicrobial resistance is going up everywhere, but the second is that the UK, thanks to the work of PHE and others, is much less badly affected than so many other countries in Europe, and that is due to very strong work from many people here, and there's some excellent sessions later on antimicrobial resistance. But my challenge, my final challenge, which I think is an area which we are collectively failing on, is if you read most things about infectious diseases, you would believe that the great majority of problems in infections are in children and young adults. That is not true. The great burden of disease in our country now, and increasingly, is in the elderly. And that is for several reasons. The first, as you all know, is the incidence of infectious diseases is massively greater as you grow older. So although there is a peak up in the first year of life, you really have relatively small chance of infection through till you're around 65, 70 kind of period, at which point it starts to go up very rapidly. So incidence is massively greater in this population. And this is important because, as we all know, the population over 80 is rising very steadily and very rapidly. Within 3 decades, we will have twice as many people in that age bracket as we have today. But it's not just incidence. As everybody in this room knows, severe disease tends to congregate in the very young and the elderly. But we have had and on the left-hand side, what you can see is, as a proxy, hospital admissions for infections per 100,000. And as you can see, the big line bars are in the very young and the very old. But if you look at mortality on the right, and this is direct infection deaths, what you see is that the deaths in young children have virtually disappeared due to a combination of public health and clinical measures. But those in the elderly are very substantial. That is where the great majority of mortality and morbidity from infections exists. And we now have increasingly solid evidence that it is not just direct cause of infections that there's an issue, but if you look at cardiovascular disease for certain, stroke and heart disease in particular, myocardial infarction, there is now really clear evidence that significant infections in the elderly, and probably even trivial infections in the elderly, lead to a substantially increased risk for quite a long period afterwards of myocardial infarction and stroke. And I think we're likely to see this is true for other things as well. So, in fact, the figures that we see for infections in the elderly killing people and causing significant morbidity for things like delirium are only the tip of a large iceberg of non-communicable disease driven by infections. And I think concentrating on infections in the elderly is something which is, in my opinion, well overdue. Over to you, Sharon.
Very much. Thank you very much, Chris, for showing us some startling and extraordinary evidence on the way we can control infectious diseases in this country. Now, the infectious diseases strategy. The very most important thing I'm going to say today is actually thank you. I want to thank all of my colleagues who've helped put this strategy into a reality, into a booklet that you can have a copy of here, or you can go online. So this is live online now. But a big thank you. And I would say that the other thing is that this is a new way of working, where 3 directorates across PHE are coming together to work together in a cohesive and coherent way. So I'd like to thank my 2 other co-sponsoring directors, Yvonne Doyle, who's the medical director and director for health protection, and Sue Ibbotson, who's the Centre Director in the West Midlands. I'd also like to thank everybody that's worked in the strategy group and in the strategy committee, including Mark Driver sitting at the front here, who's been driving the efforts. But this is the work of many hundreds of people. So thank you to them. Now, I'm going to start. When we think about building an infectious diseases strategy, where do you start? Well, I think what we do is we build on our past success. And what I've done here in this slide is just to give you a flavour of some of the successes that we have year in, year out at Public Health England. Now, the first is the staggering number of incidents and outbreaks that we deal with. So emergencies including measles outbreaks, meningitis, listeria, and even the first case of monkeypox in the UK. There's an interesting case study in the strategy if you're interested in that. So this is us working 24/7 every day of the year to protect the public from threats from infectious diseases, which is quite a remarkable amount of work. Now, we've already heard about the great success of our national immunisation programme. This is something that people from other countries see as an exemplar for the way immunisation can be delivered to our population. And we prevent a staggering 2.75 million cases of infectious diseases every year through that strategy. And we've already seen some of the figures for the individual diseases, such as those associated with meningitis. Now, I'm very proud of our lab network. We have a reference lab in Colindale and a lab in Porton, together with a regional network of laboratories. And we do more than 5 million microbiology tests every year. Now, they range from kind of the easy traditional tests such as culture-based methods right the way up to whole genome sequencing. Now, staggering, we've sequenced 100,000 genomes since 2013. And last year alone, we sequenced 20,000 salmonella genomes. And we're doing this to get better at the way we detect outbreaks so that we can nip them in the bud at the earliest possible moment. But our key successes will only occur, excuse me a moment, with the help of our people and the way that we work. So the people that work in PHE, I've been in post for 6 months, and I've been really struck by the dedication and commitment that people have and the incredible expertise that they have in microbiology and epidemiology and other specialities. It's the people is one of our key successes, in addition to ways of working. So we work together across the organisation and reach out to our stakeholders to make sure that we're providing a cohesive service. So why is the strategy needed right now? Well, this are some of the reasons. First of all, it sets out our priorities for PHE. Excuse me a moment. At this point in time, what's our purpose? Why are we doing this job? What are our priorities and how will we deliver those and measure what we've delivered? So this is a point in time when we're setting out what that is. In addition, we've already heard that there's an evolution of science and technology, and we want to really get that on board so we're doing the best that we can. But in addition, we're never going to be free of infectious diseases. There's always new threats coming along, continuing to emerge, and old threats returning. So we need to be on our guard and doing the best that we can to protect people from that threat. Another reason is that the infectious diseases strategy aligns really well with the PHE corporate strategy. So this evening when you go home and you're reading both the documents, if you align them together, you'll see that the PHE strategy contains a considerable amount of infectious diseases, including work on AMR, vaccines, emergency response, and data. So what the PHE infectious diseases strategy is a driver for the corporate strategy. Now, when we're thinking about our infectious diseases strategy, we want to build on the current challenges, and we've already heard about some of those, but I'm just going to run through a few. First, you might be surprised to hear that actually there's been 12 different emerging threats in England identified over the last decade. You can see what they are there, but you can see the examples. Zika virus, monkeypox, Candida auris. This is a nasty fungal infection caused by a pathogen that's particularly resistant to antifungal agents and affects people who are particularly immunocompromised and in intensive care unit. So these threats will continue to come at us over the next 5 years and beyond. This is looking very much through a PHE lens. We've heard about some of the other challenges, but looking through the PHE lens, we know that pandemic influenza is not a matter of if, but simply when. We know that pandemic influenza is the highest scoring risk on the National Risk Register of civil emergencies. Thank you very much. That's much appreciated. And we're a Category 1 responder. So what that means is that we are obliged to work with partners to lead emergency response. The next is measles. We've already heard about measles making a comeback. We've had outbreaks in 2018, 2019. We've already heard from Chris about AMR and new genes. Now, in our laboratory in Colindale, we've identified 19 new antibiotic resistance genes that have been detected over the last decade. This is real, and it affects everyone in this room. If you're having surgery, you're having a baby, you need a cancer chemotherapy, anything, you need antibiotics to have a good outcome. So we need our antibiotics. We also know from PHE data and others that sexually transmitted infections are on the rise. So we know that, for example, syphilis and gonorrhea in particular are on the rise, and that gonorrhea in 2017-18 went up by 26%. And we've heard a lot this morning about health inequalities. Now, Duncan's already alluded to the fact that TB is more common in particular disadvantaged groups, and if they get TB, they're more likely to die. This is a change in narrative for infectious diseases in Public Health England, because we are drawing on expertise from everyone in this room about working on health inequalities, but linking it to infectious diseases. Now, thinking about opportunities, what we're doing here again is building on what can we do to make a strategy as strong as it possibly can. So we've heard about the challenges, but here are the opportunities. And these are just two. The first is that everyone in this room is likely to be carrying a mobile phone, which connects us to everybody else and the rest of the world. Now, what we need to do is capitalise on that emerging technology to enhance data collection, analysis for decision making, and sharing. And the wonderful tool of whole genome sequencing of bacteria is quite remarkable. What this allows us to do is sequence bacteria, compare their genomes to see how related they are, to either exclude an outbreak or rule it in. So this allows us to actually pick up outbreaks even before the epidemiology has triggered an alarm bell. And it means we can act faster. We can always also use it, for example, in treatment, such as in TB. We can get quicker answers about the resistance profile of their organism using whole genome sequencing. So moving on to what's in the strategy then. I've talked a little bit about what we've included in terms of the information we've collected about challenges and opportunities. But this is our mission. So we are going to prevent, detect, respond to, and reduce the impact of infectious diseases in our population. Now, this is a really important slide. It's quite busy, but what this represents is our infectious diseases strategy framework. You can see two types of detail there. One is called core functions, and the core functions, there are 6 of them, and what these describe are what we do as business as usual, our enduring core offer. So that is to prevent infection, to detect it and control it, to prepare for an emergency and respond to it, such as pandemic influenza. We're actually a research-driven organisation, and we want to build research that improves the way we do our job. So building and applying evidence is really important. We also need to collaborate with our health protection system partners, as well as generating evidence that informs governments, that informs the public. But what I want to focus on now is our strategic priorities. Now, Duncan's already alluded to the fact that they have strategic priorities. You have to decide what are you going to concentrate on, and we've done that by taking the best possible evidence from internal and external experts, relating that to what's going to give us the best possible outcome for the work that we do in terms of health outcomes. So there are 10. The first is around vaccines, and we want to optimise vaccine provision and reduce vaccine-preventable diseases. The second is to be a world leader in antimicrobial resistance. The third is around data and infectious disease surveillance. We need to capitalise on what I was talking about earlier, which is about emerging technologies. And the fourth, we've already heard about, we need to eliminate hepatitis B and C, TB and HIV living up to our commitment to the WHO for elimination targets by 2030, and we need to halt this rise in sexually transmitted infections. Moving on to number 5, which is under prepare and respond, we need to strengthen our response to major incidents, so when the next pandemic comes, we will be ready to tackle it. Number 6 builds on health inequalities and gaining the evidence to understand how we tackle these. Number 7 is around whole genome sequencing. There's work to be done to still continue to embed that technology and, more importantly, actually understand how people use the data that we generate to greatest effect. Number 8 is to integrate and strengthen our health protection system, and together with number 9, which is strengthening our global health activities overseas. Now, this is important to help countries reach their international health regulations, to control their antimicrobial resistance, to detect and control outbreaks. These affect people overseas and affects people in England too. And finally, when we've done that, what we're going to do is gather all that evidence together to demonstrate what this strategy has delivered. Now, I'm going to very briefly mention 3 strategic priorities just to give you some sense of what we're doing in each. So the first is vaccines. Now, we do know that after clean water, vaccination is the single most effective public health intervention we could possibly do. So what we need to do is work with the Department of Health and Social Care and NHS commissioners and providers and other key partners to deliver our vaccination programme. Now, we know that parental confidence in the immunisation programme is actually at an all-time high, and that parents trust information from healthcare providers more than they trust any other source of information. But we need to maintain that confidence in us through our Values of Vaccines campaign. But in addition, we need to work to make vaccines accessible to busy parents who are juggling their lives and their works. So accessibility, we know, is something that will make a difference to vaccine uptake, together with convenience, reminder letters and so on. We also, in Public Health England, have a duty to develop evidence to show the efficacy of new vaccines that are being developed, and to give advice to the Joint Committee on Vaccines and Immunisations about what should be included in our vaccination policy. Now, this is about health inequalities. Now, it's simply not fair that some people in our society are getting a raw deal in terms of the number of infectious diseases they have and the outcome from it. So people in underserved populations, such as the homeless, also people in prisons, they have a higher rate of TB, bloodborne viruses and other infectious diseases. So we're going to have a focus on those people to look at how we can have targeted outreach to those people so that we can treat them more effectively. Going back to what Chris was saying about the elderly, we're also developing a work stream relating to healthy ageing and infectious diseases. And finally, I'm going to talk for 1 minute about antimicrobial resistance. So we need to control this in the UK and overseas, because what we generate here will actually travel overseas and vice versa. This is a global problem, as Duncan was saying. So we really need to understand better the impact of optimal prescribing, how we do surveillance to spot problems when they're emerging so that we can nip them in the bud. We need to understand how to intervene to prevent infections spreading from one patient to another. And we need to then understand, when we have a rare event, to understand the tipping point from that going into something that's much bigger than just a rare event. So this is my closing slide. What I would say is that our ambition for the future is really built on our legacy from the past. So we're really working on the shoulders of giants that have gone before us. Now, we started with a public health laboratory service back in 1946. Graham Wilson was the director, and we've had an evolution through Health Protection Agency and into Public Health England. Now we're looking at our first PHE infectious diseases strategy, and it's our responsibility to take this forward into the 21st century to make the very best possible efforts to tackle infectious diseases and protect the people of this country. Thank you very much. So at this point in time, I believe that we have time for some questions. And so we're going to, I hope, sit over there. Our microphones will be turned on, and we look forward to answering any of your questions.
Thank you, Sharon. Thank you, Chris. Who would like to ask a question? Yes, thank you, Ben. Can you just say who you are, Bren?
No, I won't, Duncan, sorry. Hello, my name's Bren. I just volunteer in the local community and just wanted to make a comment on what Duncan was saying about speaking up. You know, I have the privilege to work with a number of communities in terms of health inequalities day after day after day, and I've done for about 25 years. But what we have to do is we have to create the environment for leaders to listen up. So I'm changing it slightly round or whatever, really, and putting it on our leaders to create that environment for people who might find it difficult or sometimes impossible, really, if I'm honest, to feel that they can speak up. Point one. The second one on the health inequalities, I'm really glad and for the panel that we've got that in and it's explicit. I often see it's implicit, but it's really explicit here. And my one question is, when we're looking at targeting some of those community groups that are not hard to reach, but our services are hard to access, is in what approach we're going to do it, because we've tried this a number of times, and I'm not sure we've got it right, and I'm not really sure we've got it right because we don't look for those champions in the communities at the start. So I'd just like a comment on that one.
Ben.
And thanks for your leadership, Duncan.
Thank you, Ben. We'll take a second question. I think up in the top right hand. Yes. Hello.
Hi, Graham Dixon, Agencia Limited. My question is in the context of international outbreaks and rule of law. We're doing a lot of work out in places like Kenya, where if you're ill, what hospital you end up at depends on the bribes paid to the ambulance drivers who may or may not pick you up. Are the international efforts of PHE actually being tied into anti-corruption and things that will affect the infrastructure, which can obviously greatly impact on the outcomes of infectious disease outbreaks?
Thank you. Is there a further question? Yes, in the middle here. Thank you. Can you say who you are, Rachel?
Rachel Flowers, Director of Public Health of Croydon. Brilliant presentations both, thank you. What many of us are wrestling at the moment, certainly within local authority as well as the NHS, is the prevention message around sexually transmitted infection. We're focusing quite a lot on treatment. We're now seeing more complex sexually transmitted infection. We seem to have forgotten the prevention message. It would be really great to have more prevention messages nationally, please.
Thank you. Well, who would like to start? Sharon?
I can start. I'll start backwards, if I may. So absolutely with you on the condom issue. If we're going to prevent sexually transmitted infections, then condom use is a key public health message. And that has to be an important strand in our advice to people. So I think I'm simply agreeing with you. The issue over health inequalities and difficult to reach populations, there is work that we can do, but it will need us to go to individuals and to seek out in a seek and treat type model. Now, you'll see that the health inequalities was under the research strand, building the evidence. And I would say that in infectious diseases, we're just moving into this area of health inequalities, which is so critical, but we're going to draw from expertise across the organisation, which is actually steeped in expertise in this area, to understand how we best study infectious diseases and health inequalities. But my own sense is that infections in people with homeless absolutely needs a going out to treat philosophy, and that's what we're thinking about at the moment in terms of those populations. The issue about Kenya and bribery, I feel that that's two things to say. One is that we have a global health strategy that's being written at the moment and be released towards the end of this year or early part of next year. Our strategy will be of a huge support to that, I believe. But we are not going into the area of bribery and corruption, which I believe is beyond what we are able to tackle when we're thinking about infectious diseases. But Chris may have something to add to that.
On the issue of inequalities, I mean, everyone in this room will agree with you, and absolutely agree. If you don't tackle inequalities, you're never going to get to the root cause of infectious diseases. Infectious diseases always cluster towards the poorest, the most marginalised, the most vulnerable. That is where they will be. In poor countries, in middle-income countries, as Kenya is increasingly becoming, in high-income countries such as our own. Everywhere in the world, that is true. On the issue of prevention, I think we still have quite a way to go. And realistically, selling a prevention message was easiest, sadly, at the time when treatment for HIV in particular was less effective than it is at the moment. And that has taken some of the edge off our ability to say to people, you absolutely must do this. But we should also be honest and say that even at the point when we had an incredibly strong drive, our methods of prevention were never very effective. And I think we need to put a lot more work into working out better ways of persuading people to do things which maintain a fantastically happy social life in all its forms, whilst protecting themselves from infections that will make them have a bit of a kind of morning after feeling. So that is absolutely critical.
Can't wait.
That wasn't meant to be about you.
Yeah, but all applies, you know. So listen, we do have to move. It's a great start, and you know the inequalities theme brought beautifully to the fore. And Chris about the elderly, and lest we forget, and where we need to have our greatest focus. So great to have both of you here. Thank you very much, presentations, and to everyone for joining in. You do not have much time to get to the next session, so can you get there just as quickly as possible? Thank you.